Greetings, my name is Rania and I'll be presenting to you about menopause and beyond. The outline of my presentation will cover introduction, symptoms of menopause and long-term consequences, how to diagnose menopause, and a topic that is of interest to me but unfortunately has received little attention in the literature and research, and that is a topic of menopause as a public health concern. And then we'll look at management of menopause. And before I conclude, a little bit on what's beyond menopause. So, what is menopause? Natural menopause in a healthy woman refers to permanent cessation of menstrual period, and that is dated from the final menstrual period, followed by 12 months of amenorrhea. And I say natural menopause because, as we all know, menopause can be iatrogenic. It can be due to surgery, radiation, or even certain pathologies. According to UpToDate, the average age of onset is 51, but it is affected by a number of factors such as genetics. If a woman has a family history of early menopause, then she is at risk of getting into menopause earlier. Things like smoking. Smoking, it is documented to reduce menopause by approximately 2 years. Interesting enough is that even passive smoking may be associated with reduced age of onset of menopause. This natural process that leads to menopause is associated with the natural depression of follicular function that then leads to a high rise of follicle stimulating hormone and hypoestrogenemia. In a woman who is less than 40 years old that has manifestation of symptoms of menopause in association with amenorrhea, it is appropriate to refer to her as having premature ovarian insufficiency, or POI, or as some literature may refer to it as premature ovarian failure, rather than referring to her as in menopause. You might have heard of terminologies like premenopause, perimenopause, and postmenopause. Unfortunately, these terminologies are sometimes used inaccurately. Hence, in 2001, the Stages of Reproductive Aging workshop divided woman-female reproductive aging into stages with the aim of clarifying terminology relating to menopause. The Stroll staging system is considered to be the gold standard for characterizing the reproductive aging from reproductive years through menopause, and it is based upon the bleeding pattern or the menstrual cycle, the endocrine findings and symptoms. The transition from reproductive to post-reproductive life is divided into several stages, with 5 stages preceding the final menstrual period and followed by 2 stages. The reproductive stage, or premenopause stage, is divided into 3 phases: the early, the peak, and the late. Oocyte undergoes atresia throughout a woman's life, with the follicular quantity and quality undergoing a critical decline approximately 20 to 25 years after menarche. The menopausal transition, or as known as the perimenopause or the climacteric, is a transition period from regular menstruation until menopause. This phase or this period may last for 5 years or even more, can be highly variable in duration. but it is characterized by menstrual cycle changes that include variable cycle length with skipped periods and increasingly longer intervals of amenorrhea. The perimenopause period also includes the first 2 years of the postmenopause period. The postmenopause period then followed until the rest life of the woman. With regards to the menstrual cycle, we have already mentioned that there are changes in the menstrual cycle, starting with irregular cycles to periods of amenorrhea, which becomes more prominent in the late phase of the menopausal transition. And eventually, the woman will be completely amenorrhea throughout the postmenopause period. With regards to the symptoms, the woman in the early stage of the menopausal transition may sometimes not manifest any symptoms at all, and the only complaint will be the irregular menstrual cycle. However, as the time goes from the late phase of the menopausal transition, women can manifest vasomotor symptoms, which we'll talk about later. The vasomotor symptoms become even more severe in the early stage of the postmenopause period. However, not only the vasomotor symptoms manifest in that period, they can also complain of urogenital symptoms. But the urogenital symptoms becomes even more severe in the late phase of the postmenopause period. The endocrine changes, the AMH, the inhibin, due to the depletion of the follicular function, this hormone, as well as the antral follicle hormone, becomes very low, which then leads to a rise in the follicle stimulating hormone. But this becomes significant in the menopausal transition and even more pronounced in the late phase of the menopausal transition and the early phase of the postmenopause. Somewhere in the mid stage of the postmenopause, the follicle stimulating hormone stabilizes. So we have seen on the stroke staging system that the vasomotor symptoms are more prominent in the late phase of the menopausal transition to the early phase of the postmenopause. They manifest in about 80% of women and 20% of women having severe symptoms, but unfortunately only 20 to 30% will seek medical attention. The mean duration of the postmenopause symptom can be up to 4 years, but in about 10% of women, these symptoms can last up to 12 years. The hallmark of vasomotor symptoms of menopause is hot flashes, and this is associated with a change in the thermoregulatory center, which unfortunately is not well understood. But hot flashes typically begin as the sudden sensation of heat, which is centered on the upper chest and face, and rapidly becomes generalized. The sensation of heat can last from 2 to 4 minutes and is often associated with profuse perspiration and occasionally palpitation, and sometimes followed by chills and anxiety. The hot flashes occur mostly at night, which then leads to sleep disturbances. Due to estrogen deficiency, there is decreased in blood flow to the vagina and vulva, which leads to genital atrophy, and women who complain of vaginal dryness, itchiness, and regular discharges. And this will then also affect their sexual function and complaining more of dyspareunia that leads them to having decreased libido. Depression has also been noted to occur as new onset during menopausal transition, with women who already have had pre-existing depression suffering or experiencing the symptoms even more often in their menopausal transition period. Women in their menopausal transition, and especially the ones in the postmenopause period, also experience cognitive changes. They have problems with memory and even difficulty in concentrating. Some of the women from their menopausal transition complains of joint pain, and these are especially women who suffer from obesity, and the symptom is also experienced more in women with depression. Estrogen is a very vital hormone to a woman's body, and its deficiency can lead to adverse outcome. It is known to bind to receptors on the osteoclast and inhibit their activity. Its deficiency can then cause an imbalance of skeletal remodeling with an increase in bone resorption that is greater than bone formation due to decrease in osteoblastic activity. This put menopausal women and postmenopause women to an increased risk of osteoporosis and bone fractures. Regarding the cardiovascular system, the estrogen aids in vascular smooth muscle relaxation, decreases inflammation, decreases low density lipoprotein levels, and increases high density lipoprotein levels. It is therefore known to have a protective effect on reducing cardiovascular disease risk in premenopausal women. With a decline in estrogen levels, this protective effect is lost, putting women at increased risk of developing coronary artery disease. We have mentioned that menopause women or postmenopause women especially have problems with memory. Their cognitive function declines, and there is accelerated deterioration in memory loss and can develop dementia. Women also complain of the fat more distributed to the abdomen and skin changes such as wrinkles. So how do we make the diagnosis of menopause? Menopause is a clinical diagnosis, with 12 months of amenorrhea being mandatory following the final menstrual period. Therefore, we need to determine the final menstrual period, which is usually done retrospectively. They can then have symptoms or they may not have symptoms of menopause, depending at what phase of the menopausal transition they are. Take note that menopause is a clinical diagnosis, but age plays an important factor. Any woman who is about the age of 45 with irregular menses or amenorrhea and menopausal symptoms, you do not need to do any further investigation. You can safely make the diagnosis of menopause. However, between the age of 40 to 45, if there is any doubt that this might be menopause or maybe not, then it is important to exclude other causes of secondary amenorrhea, things like pregnancy, hyperprolactinemia, and hyperthyroidism. As mentioned earlier, any woman below the age of 40 with menopausal symptoms, irregular menses, or with amenorrhea should better or appropriately be assessed as having premature ovarian insufficiency rather than menopause. The straw staging criteria or system should not confuse us in making the diagnosis of natural menopause, as you can see that it has not only included the pattern or the changes in the menstrual cycle and symptoms, but it has also included the endocrine findings. Take note that inhibin B, the AMH, and AFC have all been used to assess the ovarian reserve in the setting of assisted reproductive medicine, but none of these hormones are validated for the evaluation of menopausal status. Therefore, menopause is a clinical diagnosis, and you do not need to do any bloods to confirm the diagnosis of natural menopause. In medicine, one always makes room for exceptions. I did stress that menopause is a clinical diagnosis, but sometimes making that clinical diagnosis might not be that simple. This is especially true for women who have had menstrual cycle disorders or irregular menses throughout their premenopause period. So the true criteria of the menstrual pattern might not apply to them. Women who have been on oral contraceptives might not experience the vasomotor symptoms and might not have irregular menstrual cycles. People who have had hysterectomy and endometrial ablation due to the absence of their menstrual flow. So this group of women, we might actually not know when they have entered the menopausal transition. In this case, you might then need to consider doing the hormonal profile just to confirm the diagnosis. And of course, the age factor will guide you. Those who have had oophorectomy at any age can be considered as surgical menopause if they manifest menopausal symptoms. And the age factor here might not play a role. You can make the diagnosis because you will know that they have had surgery and this was iatrogenic menopause. Should menopause be considered a serious public health concern? Well, it is probably a topic for debate. But how many will agree that they have heard of hot flashes and that it is part of menopause and that's the end of the discussion? How many women know exactly what menopause is all about? What about other symptoms of menopause? At what age should we start educating women about menopause and society at large? What can be done about these symptoms of menopause that affect so much the quality of life in women? How many women are offered treatment or hormonal therapy at all in the public health sector? Some women might not even raise complaints about their menopausal symptoms because they are told that their grandmothers, their mothers have gone through them, and so they suffer in silence. A study done in Bangladesh looked at menopause and society, and what they find out that there was a big difference between the perception of the well-educated woman and those with poor socio-economic background. Women in the urban areas had better understanding of what menopause was all about, and they tolerated symptoms, and they did seek medical assistance better than the woman in the rural area. Same applies to the society. Those who were more educated viewed women in the menopause phase or the post-menopause women better than those who are from the poor socio-economic background. Another study conducted in the rural villages of Limpopo, looking at the perceptions of menopause and aging. Although the study was done only in the rural villages, the findings supported that women with poor socio-economic background and poor level of education understood little about menopause. They also made comments in the article that they felt discriminated, and they not only suffered from the symptoms of menopause, but they also lacked support and respect from the society. Of interest was a remark made in the article that says, the social construction of menopause is viewed as the entry point to old age and represents a challenging and often difficult time because whilst women may still feel rather young and full of energy, society has a tendency to perceive them as increasingly less attractive and less fully functioning. The time of menopause is characterized by a series of losses, including loss of youth, beauty, fertility, libido, and health. While menopause naturally affects the cognitive function and cause fluctuation in women's mood, it is no doubt that the society's perception on menopause can aggravate their symptoms, leading to the disruption of the psychosocial well-being. Hunter and Randall then looked at a possible woman's reaction to hot flashes. 56% of women feel physical discomfort due to heat and sweating, and about 53% will feel irritated and annoyed, and often they will respond as, "Oh no, not again," while 40% will complain about sleep disruption and feel tired. 20% might have feelings of despair and helplessness, and often wonder, will this ever end? About 36% will be socially embarrassed, and 17% will actually develop social anxiety because they wonder if everyone is looking at them when they are sitting in the meeting and having a hot flash. 18% will lose control, and 8% of them would actually say to themselves calm thoughts because they then will not be able or feel free to complain about their hot flashes to their partner or family because everybody is tired of them complaining about these symptoms over and over. And so they say to themselves, just take a breath and it will go away. Well, having heard all that, it is clear that menopause can have a very negative impact on women's quality of life and their economic contribution to our society. In an article, New Menopause Guideline Implications for South African Clinicians was the title. Professor Alberstein said it beautifully. When considering the health cost of treating menopausal symptoms, the reduced productivity of women undergoing menopause needs to be taken into account. And he stressed that this is particularly true in our society today, where women are the key to the productiveness of many sectors of our economy. Well, I should say no more as to why menopause should be considered a serious public health concern. And so we move to the management of menopause. The treatment goal of menopause is to improve the quality of life. We have heard of perceptions of women and society on menopause. Perhaps it's time we implement menopause health awareness, and not to forget educating women on living healthy lifestyles. Things like stopping smoking, eating healthy, maintaining a normal BMI, regular exercising, stress control, and of course, optimizing treatment for chronic conditions. But sometimes one may wonder, what defines quality of life? In 1995, David and Jonathan looked at the 5 domains to define quality of life. And they looked at the overall general well-being that comprises of the social well-being, that is their physical function, the social well-being, that is the interpersonal relationship, be it family or the level of community acceptance and support, development and activity, concerned with possession and use of skills in relation to both self-determination, competence, or independence. The material well-being subsumes the finance or income, their sense of security and stability, their emotional well-being, how is their self-esteem, the status in the society, and respect from the society. You're probably asking by now, when is she going to talk about hormone therapy? There is quite a number of studies conducted on hormone therapy and menopause, and a number of publications about it. Some people refer to it as hormone replacement therapy, and others call it menopausal hormone therapy. But in the revised consensus position statement on menopausal hormone therapy of 2014, the South African Menopause Society emphasizes on initiating menopausal hormone therapy during the therapeutic window of opportunity. This is the menopausal transition period, and it should be initiated in women with menopausal symptoms after discussing the benefits and risk of hormonal therapy. And of course, we need to have a thorough medical background history and physical examination, for not all women will qualify for hormonal therapy. Do not forget the contraindication to hormone replacement therapy. In the absence of contraindications to hormone replacement therapy, any woman with vasomotor symptoms or urogenital symptoms that affect her quality of life should be offered hormonal replacement therapy. Some indications are prevention of bone loss in women with premature menopause, and also indicated as treatment of osteoporosis in women at the age of 50 to 60 who are at risk of fracture, whether they have or may not have vasomotor symptoms. The contraindication to hormone replacement therapy are such as breast cancer, whether current, suspected, or past history. But that is controversial regarding the past history of breast cancer. Women with suspected or known estrogen-dependent tumor, those with undiagnosed abnormal uterine bleeding, or with untreated endometrial hyperplasia, women with current or previous idiopathic venous thromboembolism, those with severe uncontrolled hypertension, or with arterial coronary heart disease, active liver disease, thrombophilia, and porphyria are also contraindications to hormonal replacement therapy. So what are the benefits of menopausal hormone therapy? Hormonotherapy improves quality of life through the relief of vasomotor symptoms and improvement of sleep. The vulvovaginal atrophy or the urogenital symptoms can be improved by systemic or topical estrogen therapy alone. There is also evidence that hormonal therapy decreases fracture by 50% if initiated before the age of 60 or given within the 10 years of onset of menopause. But supplements of calcium and vitamin D is also recommended. As said, estrogen does have a protective effect on the cardiovascular system. Estrogen in standard dose alone may offer protection against coronary heart disease when initiated in the menopausal transition period. The We and Her study showed that hormonal therapy does not offer secondary protection against coronary heart disease. But we need to consider the fact that the um, average age of the participant in the We study was 63. That means they have actually missed the boat of the therapeutic window of opportunity. And most likely, most of the participants had other risk factors for developing coronary heart disease. Hormonal therapy, estrogen, and progesterone decreases the incidence of diabetes and insulin resistance. The Million Woman study also have evidence that hormonal therapy, when initiated in the therapeutic window of opportunity, decrease the risk of developing Alzheimer's disease. Of course, hormonal therapy can have serious complications, and that is why it is very crucial to weigh the risk and benefit of therapy. The We study have shown that there is an association between the venous thromboembolism and hormonal therapy. It shows that 18 per 10,000 versus 7 per 10,000 participants developed venous thromboembolism, and the risk was increased with estrogen progesterone therapy versus the estrogen only therapy. There is also evidence that the route of administration has an impact on the risk of venous thromboembolism, the highest risk being from the estrogen progesterone therapy, followed by oral estrogen therapy alone, and the lowest risk with transdermal hormonal therapy. In women with a uterus, avoid using unopposed estrogen due to the risk of developing endometrial cancer. The Her study showed no evidence of role in the prevention of stroke, but we need to consider that if therapy is initiated in the therapeutic window of opportunity, and if all the other risk factors such as hypercholesterolemia or high blood pressure are controlled, then the risk becomes lower. There is also data that suggests that hormonal therapy is a promoter of pre-existing breast cancer, and this risk is high in women who receive estrogen progesterone and lower with estrogen only therapy. The evidence of the association of hormonal therapy and breast cancer was obtained from the Million Woman study. Any woman with premature ovarian insufficiency or POI should be initiated on hormonal therapy until the age of menopause. So what hormonal therapy is out there? The estrogen known as Premarin is a drug that has been on the market for a very long time, and it's widely used in the public health sector. The private health sector, this might not be the case. There are two ways of giving hormonal therapy, either as estrogen only therapy or estrogen with progesterone therapy. The estrogen only therapy should only be given to women post hysterectomy. The dose of Premarin is 0.625 milligram, and that is the standard dose, which can be administered orally as tablets or as a topical vaginal cream or as a patch transdermally. The reason for giving progesterone with estrogen to women with a uterus is for endometrial protection and prevention of endometrial cancer. The progesterone can either be given as sequential or continuous therapy. The sequential therapy, you give Premarin 0.625 milligram and you add on medroxyprogesterone acetate 10 milligram given 10 to 14 days per month. Or you can use micronized progesterone 100 milligram. With continuous therapy of progesterone, you give Premarin 0.625 milligram and you either give 2.5 milligram or 5 milligram of the medroxyprogesterone acetate on a daily basis. There's a wide variety of hormonal therapy in the private sector. The new third generation selective estrogen receptor modulator being talked about is the ospermifene, which is known to have effect in the relief of vulvovaginal atrophy and especially combat dyspareunia. The bazedoxifene is preferred because of its favorable impact on the breast tissue and is used for the treatment of osteoporosis and vasomotor symptoms. There are other alternatives to use should there be any reason why a woman cannot have hormonal therapy. Things like selective serotonin reuptake inhibitors, the fluoxetine for example, or selective norepinephrine reuptake inhibitors such as venlafaxine or clonidine, gabapentin. And if you don't want to or you cannot use medical therapy, they can also be assisted with cognitive behavioral or relaxation therapy. The bioidentical hormonal therapy in South Africa is not yet recommended due to lack of studies, and its safety has not been confirmed. We have almost touched on what is illustrated on this graph. It is just to show what hormonal therapy to give to what group of women with what type of symptoms. For instance, women with vaginal symptoms only, vaginal estrogen might be adequate. And women with a womb, remember, should not be given unopposed estrogen. So you can either choose hormonal therapy based on whether their last menstrual period has been less than a year or more than a year. The progesterone here has also been used in the form of levonorgestrel containing intrauterine system. Take note that estrogen only can be given to women post-hysterectomy. Some women also suffer from hypoactive sexual desire disorder, and unfortunately testosterone in menopausal women or in women has not been recommended due to lack of study. So tibolone can be administered or is recommended for women with such a disorder. And lastly, beyond menopause, we now know we need to determine the final menstrual period, followed by 12 months of amenorrhea to make the diagnosis of menopause. So beyond menopause will then refer to the post-menopause period. With aging comes increased risk of other issues, such as different types of cancer, and coronary heart diseases increases following menopause. We also know that menopausal symptoms continue 4 years after the final menstrual period, and these are commonly the urogenital symptoms. But in 10% of women, the menopausal symptoms can last for 12 years. So 10% of women might actually need to continue with hormonal therapy in their post-menopause period. According to ACOG, the absolute risk of venous thromboembolism is age-dependent in women taking hormonal therapy. And we also know that the women in the post-menopause period are not that very active, and some might even be immobile. And that on its own is a risk factor for venous thromboembolism. But the real question here is, should we discontinue hormonal replacement therapy by the age of 65? What if a woman is 70 years old and is concerned about her intimate relationship with a partner? Maybe vaginal estrogen is all that she needs. We also now know that the route of administration have different impact on the risk of developing venous thromboembolism. Perhaps we need to switch from the tablets to a patch in this group of women. What if the menopausal symptoms such as vasomotor or urogenital symptoms is not really what bothers these women in the postmenopause period? How many women have you seen being dropped by at the hospital and nobody ever get to pay them a visit until they are either discharged or until you contact a social worker to find them a replacement? Some women view old age home as a place where they go to wait for their death. What if the fear of death is what actually troubles the woman in the postmenopause period? What if they suffer from the lack of support from the society or even family at times? How is their psychosocial well-being? Perhaps we need to conduct more studies on perception of women in their postmenopause period. Yes, aging is a natural process, but unfortunately it can be a very detrimental life experience to some women. In conclusion, menopause is a serious public health concern and has a negative impact on women's quality of life. We need to conduct more research on women's perception of menopause and society's perception. We need to educate women on hormonal therapy and empower them to make the right choices regarding improving their quality of life. Maybe we should implement menopause health awareness. Healthy lifestyle education should be implemented at an early stage. There is evidence that hormonal therapy is effective in combating symptoms of menopause. Whenever we initiate hormonal therapy in any woman, it is very essential that we do annual reviews of indication, the risk and complications. Thank you so much for listening to my presentation. And I would like to end it with a quote that says, "Quality of life matters as much as quantity of life."